People worry more about their hair than what's underneath. They should be worried what's underneath. I'm going to talk about cognitive resilience. First of all, Australians are getting older. About 1 in 6 of us is over 65. And by the time most of this audience is 65, it'll be 1 in 5. By the time your children are 65, it'll be 1 in 4. That's already the case in some countries, such as Japan and South Korea. Now, with age, dementia. A lot of conditions increase with age. Dementia doubles every 5 years after the age of 65. It's about 10% of all people over 65, 20% of people over 80, 30% of people over 90. Now, the good news is that we're all living longer. So if you're a 20-year-old here, you have more than 50% chance of living past the age of 80, particularly the women. That's the good news. The bad news is that you've got a 1 in 5 chance of getting dementia. Okay. But there's good news. Jeanne Calment, she's the oldest documented person in the world. She died only a few years ago at 122 in France. I think she was cycling into her 90s. She liked smoking until about that age as well. And she liked eating chocolate. I don't know what her secret was. But the point about Jeanne Calment, she was assessed by a neuropsychologist about a year before she died, and she did not have dementia. People can live a long life. In fact, 50% of centenarians have dementia, 50% don't. That's our own research. This was a Time magazine story many years ago. It was about how nuns can help beat Alzheimer's disease. How could that happen? Well, they volunteered to have their brains dissected and examined under a microscope, of course, after they died. Now, the researchers thought this was terrific, but then they found a treasure trove of files in a filing cabinet in the basement. It was their autobiographies they had written when they entered the order at about the age of 20. And they correlated how complex their neural systems had developed by looking at the grammar of their autobiographies, by the complexity of their language and their vocabulary, and found that those who had stronger elements in those areas had less pathology in their brain at death. So we have this concept of cognitive reserve. Remember the last time you had the flu? You felt foggy, you couldn't think straight, but you kept going. You went to your lectures or you went to your work. You were able to manage because you've had some reserve. And the more education we have, the more we've used our brain, the richer the neural network, and the more we can build our cognitive reserve. So there are two elements to cognitive resilience. One is cognitive reserve, which I've spoken about. The second is pathology in the brain. So let me define resilience. Resilience is the capacity to bounce back from adversity. So people can be resilient after a tragedy and bounce back, and they eventually come back to normal. So we measure cognitive resilience by looking at the cognitive abilities despite the pathology. And the way we've done this in the past is to have examined people or tested them before they died, hopefully fairly recently before they died, and compare it to the pathology in their brain at post-mortem. But now, there's such a number of developments that we can look at the brain's pathology in life. There are huge advances in imaging of the brain, not just CT and MRI and PET scans. Now there are amyloid PET scans, the toxic protein that builds up in Alzheimer's disease. There are tau PET scans, the second toxic protein that builds up in Alzheimer's disease. And we can see how much pathology there is. There are also blood tests coming. They're here, we're using them in research, and they'll be here for clinical use for Alzheimer's disease. So there's been a shift. We can now measure cognitive resilience in life, and that's been very exciting for researchers. We know that of people who've died and had post-mortems, only 50% of their cognitive decline, these are people with dementia who died, could be explained by pathology. There are other things happening. And the reverse is true too. People who had normal cognition and had the post-mortems, almost half of them had lots of pathology in their brain, but still they were functioning normally. They had cognitive resilience. They had the capacity to compensate for the pathology. So that's what resilience is. Here's our brain fighting off the invaders and managing to work well. Well, the question you ask is, what can we do? What can you do? What can all of us do about this? So, as I mentioned, we've moved from cognitive resilience, but post-mortems, we've moved to looking at these images and looking at the blood tests. But can we build cognitive resilience? The answer is yes. We can try and reduce the pathology, that's what we're fighting against, but we can improve the cognitive reserve. Now, last year, a fantastic review in The Lancet estimated that 40% of the risk of dementia are things we can all do something about. In fact, if we could remove those 14 risk factors, we would have 45% less dementia in the world. There are 55 million people with dementia around the world, over 400,000 people in Australia. So imagine if we could cut that by almost half. And we do this in two ways. By reducing the pathology. So here are some of the risk factors. Checking our blood pressure and treating it if necessary. Don't smoke. Don't smoke for many reasons, not just our heart, our lungs, but our brains as well. Drinking's okay for our brains, maybe, but too much drinking is bad, very bad. Avoiding obesity, particularly in midlife, trying to avoid or treat diabetes. Inactivity is not a good thing. Air pollution, particulate matter, or nitric oxide in the air has been correlated with cognitive decline. And eating a healthy diet, mainly based on the Mediterranean diet. Lots of vegetables, legumes, extra virgin olive oil, almonds, walnuts, lesser amounts of meat, red meat, and sweets. And we can build our cognitive reserve. Yes, we can do it by exercise, both aerobic and strength. The strength training is really important, either weights or resistance training. We can do it by education, by using our brain, and the most critical time is in childhood. And that may be one of the reasons that Aboriginal people have a much higher rate of Alzheimer's and other dementias. Perhaps because of their early childhood experiences. That's something we really need to address. But we can address it in later life too, and in middle age, any time, by exercising our brains. There are brain training programs that are available, and there are learning a new language, stretching our brain in whatever way we can. Social isolation is associated with cognitive decline. And if we could build social connectedness, it's equivalent to stopping smoking. It's really important to be socially active, mentally active, and cognitively active. Depression is associated with dementia. And hearing loss. Yes, hearing loss. That was only about a decade ago we learnt this. But what's interesting, studies have come out showing that people who wear hearing aids ameliorate that risk. It's interesting with this physical activity. I wish we had a tablet which we could take instead of having to do it, but we have to do it. It works in two ways. It reduces the pathology by reducing blood pressure, by stimulating various chemicals in the brain, what they call neurotrophic factors. We have bigger brain volumes if we're doing it, and it reduces insulin resistance and makes us feel better too, so less depression. So it works in a number of ways, both in reducing pathology and increasing cognitive reserve. So our strategies, we can do it at different levels, at the personal level, at the medical level, at the community level, at the policy level. Let me go through those. So for individuals, we know that doing more exercise, eating well, exercising our brains can make a difference. There have been a number of randomised controlled trials, 5 really big ones, 4 in the last about 20 months, including one of ours. And that showed by attending to those risk factors, we could improve cognition in people at risk for dementia through age or through other factors. This was our study. It's called Maintain Your Brain, run by our Centre for Healthy Brain Ageing at UNSW. It was a digital trial. We had over 6,000 people. Half got coaching in physical activity, in nutrition, in brain training, and depression anxiety treatment, intensively for the first year, and then with monthly follow-ups till the end of year 3. The control group got information. Both groups improved. Great. But the group that got the coaching improved almost 3 times as much. And we showed it was cost-effective. Doctors have been terrific at prevention of heart disease, high blood pressure, cholesterol. We're now ready for the general practice, for primary care, to embrace brain health. All of us should be embracing it. And there's a new movement now in medicine, particularly in the UK, on social prescribing. Social prescribing is getting people to volunteer, to join into things, and to engage with nature in green spaces and blue spaces. And we can do this at a community level by providing those facilities that people can engage in those ways. And that's really important. And also having public spaces where people can sit and talk and meet and have a coffee. In Italy, you go to those towns, they all have piazzas where people can sit around and talk and meet their friends. And we need it at the policy level. We've been really pushing hard that Australia needs the slip, slop, slap of brain health. We've been really good at preventing skin cancer, stopping smoking, treating HIV. We need a public prevention program to improve our brain health. People need to be aware and take it on. It'll save money. It's cost beneficial. We need healthy brains. So can we prevent dementia? No, not yet. But we can delay its onset. For every year we can delay its onset, we reduce the incidence, number of new cases, by 10%. It's a big number. So a 5-year delay would be a 50% reduction in new cases. Ideally, we'd like to delay it till after we die. Our challenge is to have a national dementia prevention program. This has to be at a population level. It has to be across the whole life course, from education through to late life, involving primary care and scalable. And all of us, me, you, we need to be the change and push for it. Thank you very much.